How does treatment for acute lymphoblastic leukemia differ between children and adults?
First of all, children with ALL tend to have types of ALL that are more sensitive to chemotherapy. By that, I mean we're able to cure more children the first time around with treatment. Fewer children benefit from a stem cell transplant because the risk of relapse with standard therapy is lower. And children are often able to tolerate chemotherapy more effectively than older adults. Now, as I said, in children, in general, we're starting off with either 3 or 4 drugs as part of induction therapy, followed by blocks of treatment such as consolidation and maintenance in order to ensure that the person is able to achieve the deepest possible remission and to maintain that. In adults, in younger adults in particular, we often are using some of the same principles that we've learned from the treatment of children. A number of years ago, a colleague of mine, Wendy Stark, who's at the University of Chicago, published a landmark analysis comparing patients treated by pediatric versus adult oncologists in the United States. And a number of groups from around the world did the same around the same time. And we determined that in general, using a pediatric treatment approach, that about 15% more patients were able to achieve long-term survival. A pediatric approach consists of using intensified and more extended treatment with drugs that are less blood count suppressive, such as vincristine, steroids, and asparaginase, whereas more conventional adult regimens use treatment paradigms that were more blood count suppressive, using higher doses of class of drugs like cytarabine and anthracyclines, for example. Now, all of these things are important tools in the treatment of adults with ALL, and a so-called pediatric regimen is not right for everyone. But for adults up to the age of 50 or 60 years old, depending on the particular regimen, we're often able to incorporate at least some elements of those pediatric-inspired regimens for patients that have Philadelphia chromosome negative ALL, either B or T cell ALL that lacks the Philadelphia chromosome. The goal of treatment in children and in adults with ALL is cure, but the way that we get there might be a little bit different. In adults who are older, like let's say, for example, adults who are over 60 with Philadelphia chromosome negative acute lymphoblastic leukemia, oftentimes we'll use dose-reduced chemotherapy regimens. And we've been trying to leverage some of the strength of these immunotherapies, including inotuzumab, the antibody drug conjugate, blinatumomab, the bispecific T-cell engager, for example, in order to enhance the activity of these regimens without adding toxicity from intense blood count suppression for this group of patients. As patients get older, there's also a higher risk of having Philadelphia chromosome positive acute lymphoblastic leukemia. And for patients who are older with Ph positive ALL, in particular, we try to avoid the addition of intensive chemotherapy because these patients are able to do very well quite often with either just steroids in combination with a targeted therapy or with immune therapy such as blinatumomab in combination with their oral targeted therapy. In fact, those approaches that are sparing chemotherapy in Philadelphia chromosome positive ALL are becoming so effective that we're even starting to use them in some younger adults as well. However, broadly, as patients are older, we do need to de-intensify the chemotherapy in order to reduce the risks to them, both of infections as well as organ toxicities. And one goal in the field is to try to decrease the intensity of the chemotherapy without decreasing the effectiveness of the regimen. And that includes both using some of these novel immunotherapies that we have available now, as well as investigating a number of other targeted treatments or immunotherapeutic treatments to help these patients further to have better outcomes.